doing everything on everybody and you are sure you don't miss anything. That's not efficient. We want to have a problem-based approach to the patient. Hi, I'm Robert Sieber from Switzerland. I'm one of these emergency physicians, a few ones in Switzerland. Basically, I'm trained in internal medicine. Internal medicine was the first step to going into medicine, and then I realized that the emergency department is my field. Although there was no specialty, until now there is no specialty in emergency medicine in Switzerland, we keep having a group of physicians working there only in the department and trying to do emergency medicine like in other countries. Back to my roots in '98, it was the first year when I just only worked in the department. And my head told me, this will be the future. We need generalists in the next years. All the specialties, they're going beyond the needs of the people in the emergency department. We need somebody who takes care of all of them, not only just picking up the best ones for their specialties. And later on I went up to the UK to see the inside of emergency medicine and came back and was convinced that that's the real way for me to work in the future. Changing different departments made my experience, and now I'm currently working in a hospital about 750 beds, and I'm chair of the emergency department. We have only a few guys working regularly in the department, mainly the specialists coming down to the floor and seeing their patients, and we have to coordinate them. That's the real life in my hospital. However, I have to tell you that in all the hospitals in Switzerland, and we have about 120 emergency departments, the system is quite different. We have a huge mix of how patients are seen in the emergency department. But at the end of the day, we are an old-fashioned system. We lag behind how we can do emergency medicine. In my department, young doctors, interns or residents come and see the patient for a few weeks, then they rotate back to the ward, come back on the floor, and so there is no steady flow of a team. We change teams almost every week, and establishing rules and practicing guidelines is very, very difficult. It doesn't mean people are treated bad. No, I have to tell you, we have really good quality of treatment in these departments in Switzerland, and people are lucky to be there because there is no lack of anything. We can give them everything we need. However, the work in the department is getting slower and slower, more inefficient because the growing need of emergency medicine is there. People coming in, streaming in. We have, as elsewhere, more people coming in every year, about a growing rate of 3 to 5%. Because on the other hand, in our system, the problem is we miss general practitioners. General approach to the people is going less. More specialists are there practicing, but less GPs are around, which means the pressure to the ED, like some different countries as well, is growing. And we consider ourselves, the emergency physicians, like second general medical step where the people can be seen if there is no GP around. And the system provides them a good system of GP services during office hours. Out of office, there is a big problem. On the other hand, Switzerland has a shortage of physicians. We should have more physicians there really in medical school. And this means that we have a huge proportion of physicians coming from foreign countries working with us. But that's not the solution, because at the end of the day, they get the trouble as well in other countries. What does it mean now for emergency medicine? We created a society in we created the Swiss Society of Emergency Medicine and Rescue Medicine in 1990. Basis of this idea was to improve the pre-hospital care. The EMS doctors were the first emergency physicians in Switzerland, and they created this society, and there was nothing going on for the departments. Firstly, they tried to improve the ambulance care, and later on, 10 years later, we started to introduce as well emergency physicians from the department to get the emergency physician system put in place in the hospital side. And what did the society? In Switzerland, the medical general council has to control all the specialties as elsewhere. But federal law decides who is a special doctor. And this number of specialist doctors is limited. And since 20 years, there are no more specialties coming on in Switzerland. It was a decision by federal law because they thought more specialists, more costs. It's more mainly an economical reasoning to cover the number of specialist doctors. And this led us to create a supra-specialty. It's not a real specialty in pre-hospital care and in hospital care. So we have two types of emergency physicians. One, they go out with the ambulances, and the one that working in the departments. To get these super-specialties, you have to have a basic specialty. In the case of the emergency department physicians, you have to have a 5-year training program. It can be internal medicine, it can be surgery, orthopedics, cardiology, intensive care, anesthesiology, or even, no, that's all of them, sorry. These 5 years are the basis, and then you have to do another 18 months in the departments, in 2 different departments. But not all departments are allowed to train you. We have currently 15 big departments, which means more than 20,000 patients a year, and 10 teaching hospitals, smaller departments, which means at least 9,000 patients a year. Everything is small in Switzerland. That's why we're talking of these small numbers. However, teaching hospital means there is a program, a separate program in any hospital in place, and somebody has to control the teaching and have to be mentoring the people going in this specialty. We have as well, at the end of this 18 months, an exit exam, and basically the curriculum is taken from the ISM curriculum. So we're looking to get involved with, we are involved in ISM, and we would like to have at the end the same system in Switzerland like other countries have in Europe. However, the next step to have a training program, a proper training program, 5-year program, which means that's the requirements in Switzerland to have a specialty as well in Europe, means we should have an approval from the federal government. This is currently blocked by this number limiting as well. If we could apply to get a permission, we have first had to have the approval by the big societies. In Switzerland, it's a democratic rule that the big societies sustaining the super specialties as internal medicine or surgery, orthopedics, all of them, they have to approve that from the super specialty we have to change the program to a proper specialty. Without the approval of these big societies, we never ever could apply for a training program. Current negotiation told us that half of the societies support us and half of the societies are against us, which means there is nothing to go. We can't start with this program because we thought to introduce a transitional program, 5 years, based on 1 year internal medicine, 1 year anesthesia or critical care, 1 year surgical training or orthopedic training, and topped off 2 years with working in the department, which means 5 years. And exit exam, the European ISAM exit exam should have been passed. This is the idea of the program we presented to the societies, and the none of 3 of the big ones means that we are blocked in the next years. There is no way to go over this block. In the meantime, probably we will improve the program for the super specialty to get people involved, to keep them coming to emergency departments and get the training there. This is the current state and we keep going. I think it's important to understand the situation. Doesn't mean that the department is working bad. It means the patients are still cared well, but we could do that with emergency physicians more efficient. That's the main thing that we could do. We spend too much money in the health system. We should improve our way to work, and we as well should have stable teams in the departments. Currently only the nurses working there 24 hours in the same way, and only a few emergency physicians are part of this team. Most, as I told you, come in, come out, and there is no clear rules. One problem we're currently facing is the doctors coming to see their internal patients. They're doing everything in the department. The whole workup is made in the department. They don't take the patient to the ward. Everything is done on the shop floor of the department, which means they stay 4 or 5 hours there, and they are picked up for the floor when they are really worked up. However, this means the patient has to wait for results, for x-rays, and nobody bothers about the care time there. They are in the cubicles waiting on the hard beds, and decisions are delayed. It's a front-loaded medicine which not is an emergency medicine, doing everything on everybody and you are sure you don't miss anything. That's not efficient. We want to have a problem-based approach to the patient. See him, find out what's the problem, take your priorities, and then do the first step. Leave the other ones out for the next day or the other day when it's needed. Often it's not needed to do everything at the first step. There could be some efficiency. Looking at the collaboration with the nurses are the own ones in the department. Doctors, interns come down and take part of the care, but they are not part of the team. So they have a big gap in communications, and we have a big lack of guidelines and currents to stick to the guidelines, because everybody comes down and has another idea. Different departments have a different approach to the same thing. If we do an ankle sprain, from the point of view of an emergency physician, we do the Ottawa rules. If the orthopedics come down, see an ankle sprain, he do x-ray everything because he has to have an x-ray on an ankle sprain. That's the rule of their departments. That means conflicts there and more costs. Simple example, as well as we have the pain problem. They take the history and then decide what to do about the pain. We go in, we see the patient, we realize there is a pain, and we do have a pain protocol for the nurses. They can start that and they can go on. Usually the pain protocol is stopped by the interns because they're not sure if it's really needed. Okay. They block some good automatism, they block the flux of the patient. I'm convinced emergency medicine is as well needed in Switzerland. I'm a pioneer in emergency medicine in Switzerland, like a few guys around me, and I'm convinced we will go the way. It's the long way, however, we know that from the States 40 years ago, they needed about 10 years to get in this negotiation and later on. Now they are there. We are 20 years, at least 20 years behind, but we will be there as well. We keep going.